So, very good morning to one and all. First of all, I thank the Maharashtra Ophthalmological Society for giving us this opportunity to conduct this seminar. I'm thankful to Dr. Parikshit, Dr. Shirish Thorat, and of course, the dynamic chairperson of Scientific Committee, Dr. Ragini Parikh ma'am. I can also see Dr. Lahane sir has joined. So, welcome you, sir. So, without wasting much of the time, this session is on cataract and IOLs. And I have with me Dr. R.C. Shah, one of the renowned person, not only in ophthalmology, but during the pandemic, we have heard him speaking on many other topics. So he's with us. Dr. Baban Dolas is one of the other co-chairperson. And we have Dr. Siddharth Bokil, who is absent, and Dr. Bhushan. And of course, the moderators are Dr. Pankaj Shah and Dr. Rajiv Mundra. So without wasting much of time, I invite the first speaker, Dr. Maithil will be speaking on behalf of Dr. Nitin Deshpande on my experience with newer depth of focus IOL. Over to you, Dr. Maithil.
Good morning, one and all. I am Dr. Maithil Thakkar from Sri Ramakrishna Netralaya. I'll be talking about our experience with the newer extended depth of focus IOLs. I would just like to know if the screen is visible to everybody.
It's visible.
Yeah. Please go ahead.
Okay, thank you so much. So we all know that conventional multifocal lenses will give us two distinct foci for distance and near vision, but intermediate vision was not satisfactory. Trifocal lenses did correct that intermediate vision issue, but obviously the disadvantage was that the sharp vision was there only in a limited zone around the foci. The main drawbacks of these multifocals are dysphotopsias and loss of contrast sensitivity, hence the need of low addition multifocal lenses or EDOF lenses to boost intermediate performance and provide good contrast sensitivity, as the need of the day is a good intermediate vision for people in IT and other fields. I'll be speaking about four lenses which we have a little experience with, and I'll just talk about them in brief before talking about what we got. First is Oculentis Comfort and M+X. These are rotationally asymmetric EDOF lenses with 1.5 diopter add for comfort and 3 diopter add for M+X. These are foldable plate haptic hydrophilic acrylic IOL with a hydrophobic surface. They combine aspheric distance vision zone here and a sector-shaped near vision, which is here. Comfort IOL provides enhanced vision at a distance of 60 centimeters and more. Oculentis M+X provides enhanced vision for near as well. The other one that we used was Alcon VVT. They use a technology called wavefront shaping or X-wave technology, which provides depth of focus extension. So here the light is mainly confined to EDOF channel with a halo profile, which is similar to a monofocal lens as claimed by them. It utilizes almost all light entering the eye, and that leads to reduced halos and artifacts. As we can see in this point spread function, Alcon VVT lens has very good PSF from a distance, ranging from 0.5 to -2 diopters. It's much better than what we see for panoptics as well. Then the last one that we used was SIFI Minivel IOL. This lens uses the principle of spherical aberration control principle. Here the central zone has positive aberrations, spherical aberrations. The middle zone has a negative spherical aberration, and the peripheral zone is essentially a monofocal zone. These three combine to give the EDOF effect. Now what we did was we compared all the three lenses. In our study, we used this in 120 eyes. 40 were Minivel, 40 were Oculentis Comfort, 20 were Oculentis M+, and 20 were Alcon VVT. Outcome measures were uncorrected and distance corrected, distance, intermediate, and near visual acuity, post-operative defocus curve, and reported patient satisfaction and visual disturbances. As far as the results are concerned, all of them gave 6x6 vision with plus or minus 0.5 diopter sphere. As far as intermediate vision is concerned, Minivel, Oculentis Comfort, and Alcon VVT gave 20/25 to 20/30 for most of the patients. Few patients in Minivel required an add for intermediate. And for near vision, Oculentis M Plus gave very good near vision, and Vivity also gave very good near vision. But for Minivel and Oculentis Comfort, near ad was required for almost all the patients. As far as the defocus curve is concerned, here we can see for Lentis Comfort, there is a very nice smooth defocus curve with good vision between minus 0.5 to plus 0.5 to minus 1.5 diopters. For Vivity, the defocus curve was smooth for over a longer range from 0.5 to minus 2. For Lentis M plus X, there was a small dip in between for minus 1.5 to minus 2, but it improved again for the near vision, that is minus 2 to minus 2.5. As far as Minivel is concerned, again the defocus curve was very smooth and acceptable up to minus 2. There were no severe subjective disturbing symptoms. When asked about their overall satisfaction, most patients answered very high or high. In conclusion, if I were to say, Alcon Vivity lens provides very good vision for almost all distances. Lentis Comfort, good for distance and intermediate, but not for near. Similar for Minivel. And for Lentis M plus X, intermediate was not very good, but distance and near was very good. And in terms of patient comfort, they all were providing satisfactory results with minimal to no complaints of halos or glare. So
Please continue.
Side on discussion, I mean, quality of vision, patient satisfaction with Oculentis was very good with comfort for intermediate vision. And functional outcome for patients with plus 1.5 versus plus 3 was again for intermediate vision comfort or 1.5 was good, and for near vision plus 3 was good. And as far as using these lenses in post laser refractive surgery eyes, Minivel and Symphony seem to work better than M plus lens according to this study. And again, this study compared the EDOF lens with Technis multifocal lens. Here again, it was seen that the EDOF lens had better intermediate compared to Technis. Near and distance were good in both. And as far as Alcon Vivity is concerned, distance and intermediate were very good. For optimizing near vision, spectacles were required. Thank you.
Dr. Thakkar, can you elaborate on the zones of Minivel?
Yes, sir.
What are the zones which are there in millimeter, if you know?
So just 1 second.
Including VVT.
So this is around 3 millimeter zone, if I'm not
It
mistaken.
cannot be 3 millimeter. If you have a 3 millimeter, you will never get a good distance vision. Anyway, about VVT, the zone I'm talking of, the zone which you have shown 2 rings in the center. Does the company has ever told about the zones?
No, sir, I could not find much data about the zones in VVT.
What happens, I'll tell you about the except the VVT. Most of these lenses are very pupil dependent. So if the pupil size is small, less than 2 millimeter, then they accept minus 1.5 to minus 2 diopters for distance vision. They are not happy with the distance vision if your pupil size is less than 2 millimeter.
Okay.
So in case of M plus, where the pupil size is, even in our previous lenses which you made ourselves, we had to do LASIK surgery of minus 2 for at least 10 patients because the size of the pupil is extremely small. So we have to be very careful in all these lenses. If the size of the pupil is very small, please be careful or tell the patient that he may require. They are very happy with the near and intermediate. But if the size of the pupil is very small, approximately less than 2 millimeter, which is there in Indian population, you will have a problem where patients are not happy for the distance vision. This is a word of caution because I have used about 300 lenses of M plus. And all of this, whatever I have studied. And second thing is all of these lenses are pupil dependent. So if they are shifted slightly nasally or temporally, they have a double vision, especially in the evening, night time, when they are extremely happy. In fact, I am expecting one probably risky patients, which has really been extremely offensive to me that you have not informed me this. And he wants to extend the lenses, which he's very happy with everything except this small thing. And the one more experience which I will share with you with M plus and even other lenses, that if you have a large angle kappa, I had one patient, very intelligent charter accountant. He had a 0.6 of angle kappa.
Okay.
He's very happy, but when he wants to see the TV, he has to lift his chin up. Then only he can see clear.
Okay.
So these are the few points which, with my extensive experience, I think we all should keep this in mind so that we have more happy patients with us. Thank you.
Thank you for your input, sir. We'll surely keep that in mind for future patients.
Okay. Dr. Thakkar, thank you very much.
I'll just stop my slides here.
Thank you, Dr. Maithil. I'm sure the insight that you gave about the extended depth of focus IOLs is going to be of great help to everyone. And with Dr. RC's wide experience, I'm sure every talk is going to have a good insight from his perspective. The next speaker, though he is very young, but still I would say he needs no introduction. There are many innovative things which Saurabh has come up with, including the toric markers and other stuff. He comes up with every new thing, maybe every year. So let us hear something about magnificent IOL from the well-known Dr. Saurabh Patwardhan.
Thank you so much, sir, for that kind introduction. And I would like to share my video here. Just let me know if the audio is playing or not.
Yes, it's visible.
Hello, colleagues. I'm Dr. Saurabh Patwardhan from Nandadip Eye Hospital, Sangli, India. And I'll be speaking about Advanced IOL, Magnificent IOL by Care Group. The search for ideal IOL still continues. Many people, many surgeons think that monofocal is a no headache IOL. That means you just implant it and patient will have no complaints at all. But is that really true? If you see the refractive outcomes of a standard monofocal IOL, what you find is that around 80% of these patients are within plus minus 0.5 diopter of correction. These are the happy patients. But still we are left with 20% who have more than 0.5 diopter of refractive error. And does that make a change in the visual quality? Of course it does make a change. You can just see the simulated vision with emetropia in the left side, and on the right side you have patient who has got 0.75 of residual error. Obviously the visual quality for distance is quite poor. So difference not only in the distance but as well as intermediate vision is quite significant when the patient is left with a residual refractive error even with monofocal IOL. So my expectation from a monofocal IOL is that it should at least give me unaided 20 by 20 distance visual acuity, because that's what we are aiming for when we are using monofocal. Now we have IOL which is a monofocal, but it has extended depth. So the MTF value is similar to a monofocal, but it gives us range of vision. So I decided to compare this IOL, which is AS6A or Magnificent IOL, with the conventional monofocal of the same platform, which is Acryol-EC IOL. So I included 30 eyes in each group, and I included all eyes undergoing cataract with very minimal pre-op astigmatism, with expected visual of 20 by 20 and no other ocular disease, and excluded all patients with BCVA less than 20 by 30 and patient who did not follow. This was a single surgeon study, 30 eyes implanted with Acryol-EC, 30 eyes implanted with AS6A, which is Magnificent IOL. all topical phacoemulsification, and a detailed evaluation was done at 1 month. Uncorrected and best corrected vision was checked with ETDRS chart for distance, intermediate and near, and depth of focus curve was calculated for each eye after correction. These are the results. So the first application what I wanted to test the lens for is whether it improves the intermediate vision as compared to the monofocal, and this is the area which we are concerned about. And what you can see here is that the red line, which is representative of conventional monofocal IOL, and the blue line, which is representative of advanced monofocal or magnificent. You can see in magnificent there is more range of vision, which is from infinity to around 100 centimeters. So it does give you improved intermediate vision. When I compared the emetropia or uncorrected visual acuity of more than 20/30 in advanced monofocal, I found that all 100% eyes had better visual acuity for distance uncorrected as compared to conventional. Also, the intermediate visual acuity with advanced was way better than conventional monofocal IOL. The near visual acuity was not always good with advanced as well, but it was still better than the conventional IOL. So the same IOL can be used for improving the uncorrected distance visual acuity. So what you can do is you can target plus 0.25 to plus 0.5 hyperopia, and you will get most of the eyes in the range of emetropia. On the other hand, we can also use it for blended monovision. So target one eye for emetropia and target the other eye for -1 residual error. So you will get a blended monovision, and patient will get visual range from infinity to 50 centimeters. So I would call this IOL as monofocal with versatility, because you can use it for improving the intermediate vision by targeting emetropia. By targeting little bit of hyperopia, we can have improved uncorrected distance visual acuity, and we can also use it for blended monovision concept.
Thank you. So that was from my side.
Dr. Saurabh, I have one
Yes.
small comment, if you don't mind.
Yeah.
Now, I have done a lot of studies on this depth of focus. I feel that there are three factors which are very important to improve the depth of focus. One is the size of the pupil. Second is the quality of the IOL which you are using it. And the third one is the spherical aberration. Now, the spherical aberration takes a very small portion in, so we forget that part. The other two is size of the pupil. So whenever we do any depth of focus for any lenses, whether the lens is working well or not, I personally think that we should do it dilated as well as undilated depth of focus. The moment you do dilated, the small size of the pupil will be illuminated and you will get the true picture of the IOL, whether it is functioning for good depth of focus or not. That will help us, instead of any company, anybody, telling you that this is what is there, which is not the correct thing, because you have a small pupil, which is quite common in Indian population. Even in some of the monofocal lenses, you get a very good depth of focus if the pupil size is small. So you always try to dilate the pupil at least 4 millimeters, 4.5 millimeters, and you get a correct picture of performance of an IOL.
Yeah, if we want to check the performance of IOL, that can be checked even in lab using the OCAS or any other IOLA machines. But here we are checking basically the clinical outcomes of these IOLs, because we do not dilate these patients for checking post-op, because that is not natural thing which they are going to see. And your this thing is very right, that if the pupil size is less than 2 millimeter, in fact, I would advise against using even the magnificent IOL. That is because if you see the optical property, the 1.5 millimeter bump, or the convexity is there, so they will have reduced distance vision. So any pupil less than 2 millimeter, if I feel on table that this patient is going to have very small pupil post-op, I might as well, dilate the pupil little bit using maybe little stretch or something. So they'll end up with at least 2.5 millimeters post-op. So luckily in my case series, there haven't been that many patients with very small pupil. Probably because if the pupil is too small, we use BHEX or some kind of pupil dilator devices, which makes the pupil little dilated in the post-op area. But very rightly said, that is true even with IHANS, which I found. If the pupil is very small, you have to correct the pupil, and it's very easy to correct the pupil size. So I think that should not be a deterrent factor for not using EDOF IOL. We can dilate the pupil little bit with maybe stretch pupilloplasty, or even as I have shown in one of the videos, diathermy pupilloplasty we can do. So that can be easily tackled, but very rightly, that should be kept in mind when we are operating.
Well, thank you, Dr. Saurabh. That was indeed a pleasure watching that video. May I request Dr. Rajiv Mundra to invite the next speaker?
Next speaker, Dr. Shail Vasada, is going to speak on IOL implants in capsular compromises. Dr. Shail Vasada.
He has sent a recorded version. I think one of our person is going to play for it.
Yes, Sai.
Sai.
Somebody from Neurotech?
Yeah, I think so. That is what Dr. Ragini Ben has told me.
Yeah.
Yes.
You can see. Yeah.
Can we play the video, doctor?
Yeah, go ahead.
Yeah, please.
Very good morning. First of all, sincere thanks to Dr. Ragini Madam, Dr. Swapnesh Rawant, and the entire organizing team at MOSCON for having me in this wonderful meeting. I shall be discussing certain special situations where there is a capsular compromise and a toric IOL has been planned. This is a case of a 27-year-old female who had a posterior polar cataract with a pre-existing posterior capsular defect, and it was unilateral cataract, and the patient had significant astigmatism for which we could consider a toric IOL if the capsular bag remains intact. As noticed on the ASOCT, there was a large posterior capsule defect that was already there, and we prefer the femtosecond assisted delineation, also known as femtodelineation, to divide the nucleus into multiple small rings. And with modest parameters of low intraocular pressure and moderate vacuum, we are able to remove each layer from the support of the other layer. In the final epinuclear plate, what we try and do is we detach it from the fornix. So this now creates a communication between the anterior and the posterior compartment. So now a little bit of small fluid trickles back. So at this point of time, even if you come out and if you do hydrodissection, now the chances of this tear enlarging or the capsule giving way are quite less, because there will be no rise in the intralenticular pressure because of the closed space. But fortunately, we were able to remove most of it without any hydro procedures. Before withdrawing the instrument in any such situation, always form the anterior chamber. So you saw me injecting a dispersive viscoelastic to make sure that the chamber doesn't collapse. And slowly but surely, with a very slow aspiration flow rate of just 10 cc per minute. So things will happen very slowly, but things will happen under your vision and under your control. You can keep your vacuum as much as possible. Even while swapping hands, as far as bimanual irrigation aspiration goes, always form the anterior chamber, never allow it to collapse, because that can lead to an extension of the pre-existing tear or vitreous prolapse. So fortunately, we have been able to prevent this tear from extending, and there is an open defect here. Now, having had some experience of posterior capsulorhexis in children, if we can convert this irregular posterior capsule dehiscence into a strong margin, then there is still a possibility of considering an in-the-bag IOL implantation. So slowly but surely keep changing your hands from one side port to the other, from one incision to the other for ergonomic comfort, and use micro incision rexis forceps so that you can control your movements adequately, so you don't end up catching either strands of the vitreous, and you are able to control the size of the posterior capsular rexis as much as you want. So you don't want too small, but you don't want too large as well. So we were able to convert this into a posterior capsular rexis. Always make sure that there is no vitreous disturbance, which fortunately there wasn't, but we still went ahead and removed the solid gel that was here around the area of the posterior capsular rexis. So here you have the posterior capsular rexis, and this patient required a T7 toric IOL. And because now we have strong anterior and posterior capsular rexis margin, we decided to go ahead with toric IOL implantation and place it along the desired axis. Of course, in this situation, you don't go behind the IOL to remove the viscoelastic. You can give intravenous mannitol in the end. And always confirmed in the end also that there is no vitreous disturbance, which fortunately there wasn't. Even in the end, don't let the chamber collapse. Hydrate the wounds before removing the irrigation. And this is the patient at 2 months follow-up. Now he has completed more than 3 months follow-up, and the IOL is very stable and excellent visual acuity. This is the second case. Notice here that the focusing is not great during capsular rexis. It's been focused more on the posterior component or the PSC cataract, but so far things seems to be going on quite well. It was a soft cataract, and sometimes it does occur in soft cataracts that you are unable to divide it completely into 4 quadrants or any form. And this was one such situation, and therefore you can see that we are almost sort of prolapsing the entire nucleus out to the level of the iris plane to try and remove the nucleus. And fortunately, because it's a soft nucleus, it's not creating too much of a problem. But notice while the last 1 or 2 fragments are being removed, keep noticing this area. You'll notice that there is a large gap here. So there is a large anterior capsular split. Fortunately, so far it has not gone or extended up to the posterior capsule. So in that sense, we are still safe, but we want to make sure that it doesn't progress to the posterior capsule. So make sure that the chamber doesn't collapse. Again, inject dispersive viscoelastic. And while doing irrigation aspiration, this is the time where bimanual will help so that there is no collapse of the chamber. And notice here, I've kept a very low flow rate of 14 cc per minute. You can keep the vacuum as much as you want, but keep a low flow rate. The reason is so that you won't inadvertently catch with higher attraction force of the aspiration any of the remaining anterior capsular flap fragments, so that it doesn't get caught in the irrigation aspiration. So slowly but surely, I'm able to remove the cortex from the area of the anterior capsular split without causing too much of zonular stress or extension of this anterior capsule split onto the posterior side as well. And we have still been able to preserve an intact bag so far. So now this is a situation of an 3/4 capsular rexis being done and complete, and 1/4 being open. And this patient was planned for a toric IOL, and be as it may, it was to be planned in the same axis where the actual split is. So the dilemma is that should you first consider any single piece IOL with a compromised anterior capsule? Experience has shown us that if you have a good 3/4 of good anterior capsular rexis cover, single piece is not a problem. But now toric IOL, the problem is the placement axis is in the same direction, and we are worried about rotational stability of this IOL, because if it rotates, then again it defeats the purpose of the toric IOL completely. So inject the IOL. In this situation, even if you are normally injecting under viscoelastic, I would suggest to inject under cohesive viscoelastic, so that you get a lot of time to manipulate the IOL and change its position while it's unfolding, so that there is no sudden jerky opening of the IOL. So avoid injecting under irrigation in such situations and use a cohesive viscoelastic. And here I'm rotating the IOL to the desired axis, which is somewhere here at 112 degrees, before I go ahead with viscoelastic removal. Because there is an open area here, just tapping the IOL will make sure that the viscoelastic comes out from behind the IOL. And again, make sure that the chamber doesn't collapse even until the end before removing the irrigation, so that there is no forward push of the IOL and therefore rotation or the IOL coming out of the anterior capsule. So this is the patient at 2 months post-operatively, very stable IOL. Notice it's not moved forward and there has been no rotation of the IOL as well. So toric IOLs can be considered even in select cases of anterior capsular split, and stability is not an issue in the long run. Thank you very much for your patient listening, and once again, thank you for this opportunity for allowing me to present in this prestigious conference. Thank you so much.
Well, I think Shail is not available, but still watching any Vasavada's video is a treat to the eyes. So I thank Shail Vasavada on behalf of MOS. May I request now Dr. Baban Dolas to invite the next speaker?
Yeah, good morning, everyone. The IOL exchange, actually, it's a very challenge as such. I invite Dr. Ajay Paul to speak on IOL exchange in challenging cases. Is he there, Dr. Ajay Paul? Or someone is speaking on his behalf?
Ajay Paul has requested that he has some medical emergencies and he won't be available actually.
Okay, so should we go for next speaker or?
Yeah.
I think we'll go for the next speaker. Yeah.
The next speaker is Dr. R.C. Shah only. So he will be speaking on unique autofocal IOL, his design. Dr. Shah, sir, please.
One thing I'd like to mention about Dr. R.C. 20 years back, when he used to think of doing a multifocal, one name would come in our mind, and that is Dr. R.C. Shah. And pardon me, sir, if I made an understatement of 20 years.
The first one was put in 1989.
Good morning, friends and colleagues. At the outset, we feel we do have a little financial interest in this IOL. Autofocus Triumph lens looks like monofocal but works like multifocal. It is a polyfocal progressive lens without any diffractive rings. It is neutral aspheric, static. It is static and fixed in the bag. There is no mechanical pseudo accommodation, yet it functions like an autofocus lens, hence the name. There is no glare, no waxy vision, and there is no positive or negative dysphotopsia. This is the schematic diagram of autofocus progressive polyfocal optic, which gives excellent DIN vision, distance, intermediate, and near, by green technology, gradient refractive index. There is no loss of light energy because there are no diffractive rings, so there are no photons which are lost. This is the schematic optic, and as you can notice that even with different sizes of pupil, the ratio of the distribution of light remains the same. At any size of pupil, light distribution proportion remains same as it is pupil independent. Angle kappa or angle alpha are of no significance or importance. And as you can notice, there is no light energy loss because there is no destructive interference or diffraction. This is how the lens looks like in phase contrast test chamber. And this is how it looks like after implantation in retroillumination. This table of typical refraction versus distance visual acuity is very suggestive and proof of autofocus progressiveness. This binocular defocus curve of our autofocus lens indicates the excellent visual acuity through this lens at various distances. Over and above the superb best corrected visual acuity for far vision, very well balanced vision for intermediate and near vision are achieved. Please notice that there are no significant double hump slopes like in bifocal lenses. Area of focus, i.e. the area under the defocus curve, is maximized, which fairly resembles natural vision as if through crystalline lens accommodation. Contrast sensitivity is as good as young adolescent as measured on Perry-Robson chart. Any patient with clear cornea and healthy macula is fit for this autofocus lens. Like a bullet train, binocular unaided average reading speed was more than 240 words per minute. Normal anatomical variations of size, shape, and position of pupil makes no significant difference. Hence, angle kappa or alpha has no importance nor relevance. We observed that slightly slanting position such as this gives better depth of focus for near vision. These two dialing holes are also position indicators to be kept in upper half of eye. They also help to drain out any remaining retro-IOL viscoelastic. There is no neuroadaptation to multifocality in this lens. It is instantly accepted and adapted. It can be implanted in monocular cataracts also. It can be implanted in previous eye having a monofocal IOL and also in previous eye having a ringed multifocal IOL. Large horizontal oval optic covers larger and complete horizontal visual field. Hence, there is no negative dysphotopsia. An L loop have advantages that there is a 6 mm arc length contact area at capsular base fornix. So because of larger area of friction, there is a very good rotational stability. Micro serrated outer edges, which are inspired from the postal stamp, give much better rotational stability. When we implanted in second eye of previous eye having diffractive multifocal in 45 cases, all those patients said we see much better and waxy-free vision with autofocus IOL. Many of them said in our other eye, can we have an exchange of old ringed multifocal IOL with this IOL? Please note, most old-fashioned multifocal ringed multifocals are actually only bifocals. Multifocal is a misleading misnomer. Autofocus triumph hydrophilic is non-preloaded, which can be injected through any D-type or butterfly type cartridge having 2.4 mm nozzle, whereas hydrophobic version is preloaded. Gentle insertion and slow unfolding through 2.4 mm incision. Tucking the trailing loop and arranging the lens in horizontal position. Please notice, even in full dilated pupil, there is no aphakic area nor IOL border is seen in horizontal plane. Autofocus lens is large enough to cover entire pupil even in traumatic mydriasis. Hence, there is no negative dysphotopsia. Out of over 3,600 implanted, not a single patient complained of negative dysphotopsia. Autofocus IOL is semi-oval with 7.5 mm horizontal and 6.3 mm vertical diameter. Conventional 6 mm optic IOLs give rise to negative dysphotopsia due to this gap. In 18 patients who had intolerable and nagging negative dysphotopsia, we explanted conventional 6 mm optic IOL and implanted our autofocus IOL. And immediately their complaints of negative dysphotopsia were gone. We are now 101% sure that a larger diameter, 7.2 mm or larger lens, is the necessity and is the only way to negate negative dysphotopsia. A large lens has advantages. Bigger YAG capsulotomy is possible without vitreous base shift, prolapse, or traction. Even if capsular axis is not perfect in size and shape, IOLs will still be well covered by rhexis margin. In a large PC rent, we can still implant and capture. Material is such that there is no pitting of IOL when doing YAG. Even in significant astigmatism patients, we implanted our IOL. We tried to reduce by size and placement of incision on axis of plus corneal cylinder. Patients needed minor minus cylinder for distance, but none of them needed bifocal or expensive progressive spectacles. Toric autofocus is still in R&D stage. Autofocus IOL is the best choice for pediatric cataracts. These children will need only monofocal spectacles to correct their gradually increasing myopia. They will never need bifocals or progressive spectacles, which is a big recurring expense for parents for over 2 decades. No waxy or hazy vision, so no induction of mild amblyopia. In diabetics, of course, with healthy macula, we can implant this lens without hesitations because there is no double or triple diffraction of green laser spot if at all they need PRP in future. Larger size of IOL optic body is also a good advantage for retina surgeons for examination, treatment, and surgery. Because of double ring almond apple 360-degree square edge, PCO rate is low. Because of prismatic shape of square edge, we see a rainbow-like ring in retroillumination. Only about 3% out of 3,600 eyes done in last 18 months needed YAG capsulotomy. Both these eyes are 18 months post-op. You can see how clean the posterior capsule is even after 18 months. In most cases, best corrected distance visual acuity was 6.6 or better if macula was healthy. Near vision unaided was N/6 at 12 to 14 inch. Computer vision was excellent from 2 feet to 4 feet distance. Kitchen platform while standing, stair steps while going up or down, and below or under furniture vision was seen as clear as a child. Easy needle threading in low light after bilateral surgery was done. In short, after using autofocus lens, now there is nothing like monofocal or multifocal or trifocal in our practice. This is universally fit for any eye with fairly good retinal function and clear cornea. We just consider this as the ultimate premium most monofocal and keep using it as autofocus for all. Few of the satisfied patients with their results. There are no positive dysphotopsias, no glare, no halos, no waxy vision, no photic phenomena. So it can be implanted in night drivers also. In short, anyone who is fit for a progressive spectacle is fit for autofocus IOL. Thank you very much for your patient listening.
Well, thank you, Dr. RC. I may have made an understatement about the years of practice you have been doing in multifocal, but one statement which I'm making now is not an understatement, that you are a genius and out of the box thinking is there. There are a lot of questions which you need to answer us, but I think we'll cover them in panel discussion. Let me invite Dr. Pankaj Shah to invite the next speaker.
One more minute. I'll show you one depth of focus which we have not included into this. This is one. You can see up to -2, the vision is 6.4, and up to -2, the vision still remains 6.5. This is one thing, but almost 80% of the patients are similar to this. I have a record of last 150 patients with me, which probably we might go ahead with the bigger presentation world over about this lens. So this has got a wonderful depth of focus. And what I understand is that you need to have near, intermediate, and distance optics in the center of the eye. You need to have, you cannot have only near for the center and then periphery. You have to have all the three in the center of the eye. That's all. Thank you so much.
Thank you, Ashish. I think we are going to cover up not many things in the panel discussion. May I invite Dr. Pankaj Shah now?
Yeah, good morning, all of you. I invite Dr. Krishna Prasad, sir, who is going to speak on trifocal's way to go. Yes, sir, please.
Can you hear me?
Yes, sir. You are audible and you are visible also.
Thank you so much, MOS, for this wonderful opportunity. I thank the whole team of MOS always been inviting me for the guest speakers. In fact, it was a really eye-opener for me after listening to RC about the autofocus lens. I think we need to work on that. I think probably most of the companies may work on that particular future. Later on that, I think we'll not be talking much about what I'm going to talk, that is a trifocals.
This is my presented lens.
Yeah, this is my talk. Trifocal is the way to go. This is my financial disclosure. I'm consultant for Carl Zeiss India. As we all know that natural crystalline lens has got a good accommodation and it has got a clear vision in all distance, in all lighting condition, with a great contrast sensitivity, with no rotational asymmetry, with a very minimal amount of aberrations. These are the surgical options for presbyopia. If you think about the lens procedure, there are a lot of lenses available, like starting with the trifocal to the EDOF lenses. Some of my friends, even I do a lot of corneal refractive procedure for presbyopia, mainly Presbyon. There are other procedures also available in the market. So coming to the diffractive intraocular lens, what exactly it do? It utilizes the principles of diffraction in conjunction with the interference to create more than one foci. Basically, the refractive power will be on the anterior surface and the diffractive power comes from the multiple grooves on the posterior surface of the lens. The principle of this diffractive intraocular lens, whenever these plane waves are transferred into the spherical wave after the diffraction, these spherical wave propagation from different points lead to wave interference. This is a Huygens principle. So what happened? Suppose the higher the grating density, stronger is the angle of deviation of light. We have to think that. So if you have a more rings placed on the lens surface, that means higher is the add power. See, you can see in this picture, suppose if it is a shorter the width, then higher the add power. If the wider the width, then lower the add power. Suppose if you have got the lens mentioning about +4 add, that means it is around 3.2 at spectacle plane. If it is mentioning around 3, that means it is +2.25 at spectacle plane. Of course, as RC was telling that we need to now the coming days forget about the multifocal because of a lot of problems with these lenses, especially glare and halos. So nowadays, I think every patient really require this intermediate vision, especially professions like drivers, computer professions. So if you put them this multifocal intraocular lens, they have to modify their lifestyles. So that is where now I think most of us now switching on to these trifocals. Oh, what exactly happened? This is the conventional first design bifocals, where you can see the second design bifocal with the wider edge. But trifocals are a mix and match of smaller edge and the broader edge on the lens surface. So this is what I will be talking about the AT Lisa 839. I have implanted more than 1,000+ lenses in my career. So it has got a near addition of +3.3 for near vision and an intermediate addition of +1.6 for intermediate vision. So it is something called a SM smooth microphase technology. Because of that, there is a reduced potential visual disturbance and improved night vision. So compared to any other lens, one important feature about the light transmittance rate is almost around 85.7%. Because of this, patient will have a much good image quality vision. So as I was telling you, this is the light distribution for distance, intermediate and near. So most of the patients will be spectacle independence and the asymmetric light distribution in such a way that optimized for even for night driving. Very few people complaining of glare and halo, and even in reading in the night low vision light. The other great feature of these lenses, even though it's a hydrophilic with a hydrophobic surface, it's a sort of a hybrid lenses. It has even also got a 360-degree anti-PCO barrier on the posterior surface of the lens. This is just a comparison with the other couple of lenses available in the market. One is with the bifocal and one is with the trifocal lens. Even at the 3 mm people, you can see how these lenses are behaving. From 3 mm to when you go to 4.5 mm in a mesopic condition also, you can see how this 839 MP lenses, definitely the patient experience will be much better compared to any other lens in the market. This is about the far distance, intermediate and the near vision. So at the 3 mm pupil. So comparison of if you see far, intermediate and near vision in normal light condition with the optical bench measuring using a in situ eye model. This is about the loading system. Normally, nowadays, Zeiss gives with something called a blue mix injecting system, even through 1.8 mm wound assisted, or it will go very easily through a 2 mm incision. Normally, it comes with a preloaded system. Normally, the instruction given by the company, you need to just looking for when you're using for the first time, look at the instructions on the lens box. Then take out the lens from the cartridge, put it in the slot. You just press it, you get a one click sound. That means you had put it in the proper place. Always do under the microscope. Click it, then put some amount of viscoelastic behind the intraocular lens. Then push once and see, make sure that it is moving very smoothly. I never had not even a single problem with of this injecting system. I'm just showing you this one of my video. It was with a patient with the pseudo exfoliation syndrome, 2 mm pupil. You can still see that how easily you can inject these lenses within the bag within one shot. So very smooth injecting system. So coming to, this is our results of patients with 132 eyes with a 76 patient, mean age is around 58 years. Patient came for 3 years plus follow-up. You can see compared to the uncorrected visual destructive with the best corrected visual acuity, how after 3 years also patient maintaining the vision of almost 6/9 vision. Even spherical equivalent is, you can see here almost negligible amount thanks to the, I think IOL Master 700 what I've been using since last many years. So coming to the intermediate visual acuity also, 95% of the patient had a very good intermediate visual acuity. And even 96% of the patient never require wear to glasses. Only 4% of the patient really require to wear the glass. This is about the defocus curve after 1 month. You can see a smooth defocus curve. Only 5% of the patient really complaining of glare, but 70% of the patients are very happy. And only 6% of the patient really require to wear the glasses for very fine print. These are the few results. Even with the patient with a more than 0.75 cylindrical, I normally educate them go for a toric lenses. These are my results of 84 eyes with a 52 patient of tri-toric lenses. So I'll see the results are quite similar to the trifocal lenses. But what I can see is if you place it properly, of course, I do got a Callisto system with me. Only I think 80% of the patient had never had a cylinder less than, I think, 0.25 cylinder, and only 3% of the patient had some significant cylinder remaining, probably due to the misalignment of the lenses. But what I want to say, more than 95% of the patient had a refractive astigmatism less than 0.5 diopter. In conclusion, trifocal intraocular lens implantation can perform by any cataract surgeon who is aware of the principles of refractive surgery and handles the precise intraocular lens calculations. AT laser tri demonstrated excellent functional distance, intermediate and near in our clinical evaluation. Almost all patients enjoyed spectacle independence after AT laser tri implantation in this clinical evaluation. Thank you, one and all. I thank MOS once again for this wonderful opportunity. Thank you, one and all.
Thank you, Dr. Kudlu. It was nice to see you after so long.
Even to Gopal.
Yeah.
Thank you.
Hi. Namaste, madam. Namaste, Didi. How are you?
I'm very good. I thank God you corrected yourself after saying madam.
Didi.
Yes, hello, Didi. Hi, Gopal Bhaiya. Hi, Maithil. Hi, Pankaj. So Pankaj is here. And I must say that this whole year and this whole conference, Pankaj has worked so hard. All my seniors and friends, Ramesh, sir, Gopal Bhaiya are managing everything. The sessions and KP, you are the star. Without you, RC sir, Gopal and all this, these sessions would not work. Thank you. I know that you are busy and you are still finding time for us. I'm so happy.
Thank you, Didi. Thank you, Didi.
Thank you, ma'am. You are doing a wonderful job as a chairperson scientific committee, I must say.
I have good predecessors like you who work so hard.
Thank you. My basic question to the speakers would have been, before listening to Dr. RC, was, which is the first multifocal would you of your choice, whether it's a multifocal, EDOF, or the trifocal. But after listening to RC Shah, I think first I'll have answers from Dr. Kudlu and Dr. Saurabh before I move to Dr. RC.
Yeah, my preferential lens, normally I ask the patient depending upon what is their profession. If they don't have any active night life and if they are consigned to the in-house work, then my first preference is going to be the trifocal lens. If the patient really say that I drive 1 hour, 2 hours in the night, normally I prefer them to put the EDOF lenses. Then I tell the patient that you may have to wear the glasses for near vision.
Right. Dr. Saurabh?
I think there is no ideal lens. Even EDOF lens is not ideal. So we have to find the ideal patient for a particular lens. And that is the bottom line. And that is going to stay as it is for 1,000 years because these optics are not going to change. When we shift from monofocal to either EDOF or trifocal, basically there is give and take. So we are reducing the contrast in exchange with increasing the depth of focal by any of these IOLs. So I think best to find the best patient for a particular IOL. I think for a particular patient, a particular IOL suits.
Thank you. Coming to Dr. RC, your talk is something new to most of the speakers sitting here, sir, autofocus lens. Give us some insight about it and how it has an edge over the gold standard which is considered as a trifocal today. Dr. RC.
See, I was working for the multifocal lenses for years. I have visited almost all factories except Elcon. And I have learned a lot of things by sitting on a machines to find out the behavior of these lenses in the vitro as well as in vivo and correlating between the two. So after doing so many cases, I realized that the ring lenses now should be over. We are going away from the ring lenses. We need to have a varifocal lenses, whatever varieties you want to do it. More companies will definitely come. So my first choice today, even if I want to implant on my eyes, I will go for autofocus, not because it is my lens, but because the performance has been extremely good. Today in my practice, patients who have done the varifocal have sent me the patient, and all of them require to do, they ask to do the second eye immediately. Today in my practice, 98% of the patients opting for autofocus. In fact, I am almost going to close down the imported lenses forever. We are coming out with ideal monofocal lens also probably in next 3 months time, where we will not have any negative, positive dysphotopsia. It will take about 3 months time. This a 7.25 millimeter and everything has been patented by us. So this is one thing which has occurred over a period of 2 years, 2.5 years of myself, Dr. Kakadia and Dr. Vikrant from Lifeline. We have worked so hard to design this lens. And now we have come to the conclusion that this lens probably is going to be the future. We have created a company which is a cooperative society on the basis of Amul dairy concept, where all of us can become the member and the owner of the company. You become a shareholder of this company. And whatever number of lenses which we are using it, whatever profit we do it, we will distribute to all of our members as a dividend. So we are part of this money also has been put in stock exchange. So by next year, probably whatever money has been given by initial people, we will return them as a dividend. That is what our planning has been. We want to expand it to many other products also, so that all of us can afford to buy a 1/3 cost of whatever the market price has been there.
One more thing, Dr. RC, a very interesting thing about your IOL was the size of the optic, horizontal versus vertical. Can you just elaborate on it?
The horizontal size is 7.5 millimeter and the vertical is 6.2, so that the full optics covers the pupil zone even in the dilated pupil. It also covers the full field of vision. So whenever there is a negative dysphotopsia, there is usually a aphakic zones in the periphery which is responsible for negative dysphotopsia. So if you can block with the larger optics, none of our patients in 3,600, what he said, in fact, now it is more than 4,500 patients, where none of them have ever complained of negative dysphotopsia. The only one patient which got complaint was because the lens was put vertically, and we rotated the lens and the symptom disappeared. So this is a big advantage. And negative dysphotopsia, when it occurs, it disturbs quite a lot. One of our manufacturing chief in our industry has put 6 mm lens, and he has got a severe negative dysphotopsia, and he discontinued driving in the night. So negative and positive dysphotopsia and a good quality of vision for full range of vision, like from about 14 inches onwards till the infinity, is something which we all have to now accept it as a norm. One more thing I am trying to tell you is that we are trying to develop an artificial intelligence for evaluating these multifocal lenses in relation to depth of focus. If that thing works, probably we'll be able to judge our multifocal lenses ourselves and not listening to anybody. Probably it will take about 6 months to 1 year, because we are trying to get some IT people to help us so that we can develop. All of you can do it yourself, and we'll be distributing that free of charge. That the system which is there, where you feed your data and you get that whether the lens is working very well or not, which will include the size of the pupil and everything. We are trying to develop the artificial intelligence for the same.
Well, thank you so much. I thank all the speakers and the co-chairperson, Dr. RC, Dr. Babban, Dr. Pankaj, and Dr. Mundra. And over to you, Ragini ma'am, since we are exactly on time, it's 10 o'clock in the morning. So I hand over to the next session. Thank you, one and all.